In today's class, we will be discussing about HLA cross-matching and ABO sensitization while awaiting transplantation. What are the basics and the recommendations? So we know in a transplantation, we are putting a foreign graft from the same species to our body. So it is just like a foreign antigen is recognized by our body, just like a foreign pathogen is being recognized. And initially, it will activate the innate immune system, which will in turn activate the adaptive immune response, and the T cells and the B cells will be activated. So the innate immune system present these antigens of this foreign body through by means of the major histocompatibility complexes, which are coded by the human leukocyte antigen on chromosome 6. So, and which in turn activate the adaptive immune system, and the T cells get activated. They will cause direct cytotoxicity, and also they in turn regulate the B cell responses and activate the B cells for immune production, helper T cells. And also the B cells, they produce specific antibodies against specific portions of the foreign body, and they produce a antibodies will cause destruction of the graft, and also direct donor specific antibodies will cause complement will get activated, will stick to the cell surface, and that will in turn cause the complement to bind to it and causes complement dependent cytotoxicity. So this is how the innate adaptive immunity in turn results in a graft rejection. So the graft will get destroyed, cytolysis happens. So, what are these major histocompatibility complexes which are important in antigen recognition? So, they are coded on chromosome 6. There is a short arm and a long arm. The chromosome 6 short arm codes for the major histocompatibility complex class 1, which include HLA, A, B, and C. And chromosome long arm codes for the major histocompatibility complex class 2, which are HLA, DQ, DR, and DP. The most important thing of these HLAs are these HLA molecules. There are the genes of this. Each of the alleles will have multiple expressions. For example, HLA-A2 has almost 30 different allelic forms. So these are all polymorphic. So these there is a and most of these focuses are polymorphic. So there are a lot of genetic allelic variations for each of these HLA, A, B, C, DQ, DR, and DP. So for a perfect transplant, we have to match all of this allelic focus also should be matched to the maximize as possible. And another important thing is we get each gene, one half is from the paternal and one half is from the maternal. And regarding the HLA, both the maternal and the paternal alleles are co-expressed. It is not like one is dominant, other is recessive, not like that. It is both are co-expressed. And there are polymorphic alleles. And we should bear in mind that the antigenic response is not against a particular it is not against a particular molecule. It will be a particular amino acid of a molecule, that is a specific epitope of a molecule. It is known as epitope, antigenic epitope. For example, the HLA-A2, we have discussed that almost there are 30 allelic variations of HLA-A2 focus. So in that, the 62 glycine glutamic acid is a very antigenic focus. So that can, if the patient A2, we haven't gone specifically through that epitope, till that epitope, if that 62 GE, which is very antigenic, is not matched, it can result in a graft rejection in the post-transplant period. And another important thing is that this 62G crossover, that is the same antigenic epitope, can be present in B57 and B58. So if in a patient that 62G we have matched at the A2, and we haven't matched, and first we transplanted at A2, the graft got rejected, and a second time we got another donor where there is a 62G is matching at A2, but we haven't checked it at B57 and B58. There can be antigenic epitope there also because of this crossover. So all of this has to be checked for, and the PRA, that is plasma panel reactive antibody, has to be the score should be minimum. The reactivity should be minimum for a better post transplant survival and a less of rejections. So, what are the pre-transplant lab testing? Previously, we used to do complement dependent cytotoxicity testing, in which lymphocytes from a panel of group of a large allelic variation population is reacted with the patient sera, and antigen antibody complement complex formation is measured. But the problem is there can be each allelic focus has to be checked, as we have seen that there is because of the polymorphic nature of these HLA. And if because of this much polymorphism, the chances of you getting a perfect transplant match is 1 in 20,000. So that much variation in the allelic polymorphism of this allelic focus is there. So this complement dependent cytotoxicity was it is not very specific testing. Now we have gone for the Luminex assay, which is a single antigen bead assay. So in which there are multiple beads, and each of the beads will be coated by a antigen individual to each allelic focus, which are very antigenic. And we put the patient sera on that, and the cross reactivity is measured by means of immunofluorescence. So when there is a positive reaction between the antigen and antibody, there will be an immunofluorescence score will be measured, and if that score is more than 10,000 11,500, this likely that if so this is actually Luminex bioassay is a flow cell based assay, flow cytometry testing. So if you get a fluorescence MFI score, immunofluorescence measured more than 11,500, there is 95% likely that the flow cytometry cross matching is positive. And if you are getting an MFI of less than 10,000, there is 95% likely that the flow cytometry cross matching is negative. So if you are getting a borderline, that is there are few antibodies can be present. In that case, the recipient can undergo a pre-transplant plasmapheresis practiced in some settings. So if you are getting a higher PRA value means more reaction with the HLA, and you are less likely to get a matched donor. So these are the and so the mandatory testing now is single antigen bead, which is Luminex based flow cytometric assay, in which the MFI scoring should be less than 10,000. So, so how the sensitization occurs in a patient who is listed for transplantation? So, HLA antigen sensitization and also blood group antigen isohemagglutinin formation is a dynamic process. So, this can be like you are receiving a new transfusion of blood because of any infection in between, and you are getting a new antigen in your body, and your HLA got activated now. It can be a new or a reactivated sensitization, or it is because of any therapy. You have put a graft, vascular graft in your body, or you have undergone a mechanical circulatory support, which can because of therapy there can be sensitization can get altered. And another is a natural decline and disappearance of antibodies. If you have passively acquired antibodies and they have declined, then your antibodies are fallen, so you get antigenic response, or it can be isohemagglutinins. That is particularly important in children who are awaiting transplantation, because natural maturation of the immune system and the blood cells will result in change in sensitization. So these are the normal ways in which new sensitization can occur. So plasma levels of HLA antibodies and isohemagglutinin in particular in children is recommended at regular time intervals in a transplant listed patient. So what are the recommendations? That is, for a patient listed in transplant, every 6 months we should HLA sensitivity PRA panel has to be repeated every 6 months. Class 1, class of recommendation 1, level of evidence is moderate with non-randomized studies. So if there is a potentially sensitizing event has happened, then we have to repeat the HLA in 3 weeks, because 21 days is the time for making antibodies. So it is also class 1 recommendation 1 and level of evidence moderate non-randomized studies. And if the previous sensitization has happened and you are expecting that a memory response to that, that is adaptive immunity is already activated, and just it has to produce the memory responses to activated, in that in that case you have to repeat the PRA in 7 days. But here the class of recommendation is 2A, and a level of evidence is from expert opinion. And isohemagglutinin antibody against non-self blood groups for all children listed for ABO incompatible transplantation. So for an ABO incompatible transplantation in children, because it takes 6 to 24 weeks months for the isohemagglutinin to mature to adult form in children. So in that case we have to do the isohemagglutinin for pediatric patient every 4 weeks, or if 1 to 3 weeks if there is a sensitizing event. Here the class of recommendation is 1 and level of evidence is moderate with the non-randomized studies. And there are class of recommendation 2A, moderate class of recommendation 2A, that there should be maximum, we should try to reduce the chances of sensitization by reducing the exposure to HLA antigens by using leukodepleted blood products, single donor platelets. Platelets are an important source of HLA sensitization in humans. So single donor or matched thrombocytes, and also decellularized homographs when possible. So these are the ways in which we can reduce sensitization. So this is the Luminex bead spectrum single antigenic bead assay used for pre-transplant PRA panel workup. So patient at risk for a suboptimal outcome post-transplant are defined as having a PRA more than 10% or donor-specific antibodies at the time of transplantation. So it is a flow cytometry based laser-based immunofluorescence assay. So antibody production is a dynamic event, and changes in HLA antibody levels can happen even in the absence of a clear sensitizing event. So what are the potential sensitizing event? Potential sensitizing events in the body are pregnancy, transfusion of blood products, especially thrombocytes which express HLA antigen, surgical procedures with the use of human tissues, vascular grafts, mechanical circulatory support devices, and renal replacement therapy. So, de novo sensitization can take 21 days. Hence, if there is a potential sensitizing event, we have to repeat HLA in 3 weeks. That is a class of recommendation 1, level of evidence BNR. And if there is a previous sensitization has occurred and immune activation we are suspecting, then reactivation is have to be repeated in 7 days. And the children we have to repeat in every 4 weeks, because the children take 6 to 24 months for the adult titers of isohemagglutinin to develop. So what are the, from this we should understand that the potential things for HLA sensitization is these events which increases the sensitivity, like transfusion, surgery, mechanical circulatory support, vascular grafts, humanized grafts, or renal replacement therapy, and also as the waiting time increases, there is chances of sensitization to HLA increases, and the PRA score can increase, which can potentially decrease your chances of getting a favorable matching donor. Thank you.